what we know is that for upper aerodigestive cancers, and by that I mean cancers involving the esophagus, the lung, and the head and neck, there is certainly a role for using immunotherapy in the standard of care treatment of patients with both locally advanced and metastatic disease. The problem is that we have a subset of patients who seem to benefit extraordinarily, and then the majority of patients who have, at best, transient benefit from immunotherapy. So the question is, how can we build upon that? And the prevailing theme here is that, in general, we do a pretty good job of slicing up adenocarcinomas into molecularly driven buckets. So really a paragon for this is lung adenocarcinoma, especially among never smokers, where we know that driver mutations can really be not just a way of distinguishing between groups of patients, but even determining optimal therapy, either independent of immunotherapy in the form of tyrosine kinase inhibitors, identifying subgroups that are potentially less likely to derive benefit from immunotherapy, such as EGFR, ALK, ROS, and STK11, but then also potentially identifying subgroups that may be uniquely suited to benefit, such as KRAS mutant and maybe some BRAF mutant as well. In esophageal adenocarcinoma, we similarly have a pie of driver events that we're still just kind of learning how best to leverage those. We know that HER2 amplified tumors and HER2 mutated tumors tend to benefit from the inclusion of HER2 directed therapy, in addition to chemotherapy and now immunotherapy in view of the Keynote 811 study. So the question is, how can we adapt that for squamous cell carcinomas? We see across the upper aerodigestive tract really homology across these tumors with respect to epidemiology. It's commonly the case that these tumors tend to be associated with smoking and drinking. There are other environmental factors that may play a role in the onset of these tumors. There's association with some hereditary syndromes as well. And then from the standpoint of molecular biology and genetics, we see very commonly these tumors have TP53 mutations. They have cell cycle abnormalities, such as in CDKN2A and cyclin D1. And their immunobiology, probably by virtue of some of the exposures that lead to these cancers, also tends to be similar in the sense of there being increased tumor mutational burden, increased PD-L1 in these tumors. And so the question is, how can we begin to exploit that in a similar way to what we do for adenocarcinomas? So one of the ways in which we might be able to do this is by looking at immune cell populations that are present in these tumors. There seem to be differences in the immune composition of adenocarcinomas as compared to squamous cell carcinomas. So it might be the case that there are more immune suppressive or pro-tumorigenic myeloid cell subsets in these squamous cancers that we might be able to target and to suppress. Similarly, some of these genetic events may define a subgroup of these tumors that have a unique metabolic properties compared to other tumors. And so we might be able to exploit those either directly through glutamine blockade or maybe indirectly by promoting anti-tumor immunity through glutamine blockade. And then finally, there may be other subsets of tumors that have that have genetic events that confer again, pro-tumorigenic immune state. So, for example, downregulated interferon pathway signaling in tumors that have NSD1 dysregulation. And so trying to overcome that perhaps by blockade with EZH2 inhibitors. So a few different strategies to help slice up the pie, either by differential immunobiology or differential genetics.